Hello, welcome to Maternity Nursing 2 with me, Miss Kinan, and I'm presenting material in Maternity Nursing 2 prepared by Miss Jessica Train entitled Dystocia, Premature, and Postmature. So we are going to talk about dystocia. What is dystocia? Dystocia is actually obstructed in labor where there is a difficulty during labor, and it can be characterized by a slow or long labor process, which can generally caused by the discrepancy in size between the lower part of the fetus and also the birth canal. So as you can see on the picture, we have here the shoulder dystocia, where the shoulder of the baby got stuck through the pelvic bone, as well as because of the positions of the baby that is not in right position, then it slower the birth process, as well as also here you can see another position of the baby that is not in the right positions as well, then it slower the process of labor. Then over here, we can see how the baby is actually progressing through the birth canal. The baby is actually going through the pelvic bone and then the sacral bone. And as the baby turned, there is a problem that the shoulder got stuck. And then there is difficulties for the baby to coming through the labor. What is the etiology? So there are factors that characterize the dystocia in labor. The first one, dystocia power. So it means that the contraction or the his, what we call, is not normal, and the strength and the nature is not normal. So it hinders the smooth delivery. And the inhibition in contraction can be caused by inertia, or there is a weak force that prevents the cervix from opening or pushing the child out, as well as the cephalopelvic disproportion or CPD, where the pelvic size is abnormal. So it is important during the pregnancy to have a thorough measurement about the pelvic size, which then can help during the labor of the baby. Another factor that can inhibit is incoordination contractions, which the contraction happens disorganized, and also probably sometimes it's without coordination. So one time there's a strong contractions and then very weak contractions, as well as strong again and very weak, and then there will not be enough to push the baby out from the birth canal. Another cause or inhibition is about tetanic. So actually the contractions is too powerful, so that also can slow down the labor process. Another etiology is about the passage and the passenger. So if we talk about the passage, it means like the way or the birth canal. So the size and the shape of the female pelvic have some abnormalities. So it didn't accommodate, or it cannot accommodate the baby to pass. So we need then to do some maneuver to help during the labor process, or then we do an emergency C-section to then save the baby and also save the mother. And another side is the passenger. So with the passenger, what we need to be concerned about is the size of the fetus as well as the positions of the fetus. So when we enter trimester, the last trimester, we have then to observe how's the baby, how's the position, and um, the size of the pelvic. Will it then accommodate for a normal labor, or we need to do another way of delivery through C-section. So here's the picture when the baby having a head presentation, and then there is rotation and the delivery of anterior soldier, but then it's get stuck. And then when we want to deliver, or probably when we deliver the posterior shoulder, there is a problem that it also gets stuck. And also, probably there is the problem during the delivery of the lower body, and then also a problem with the umbilical cord, where probably there is not to the baby's part of the body, so it then slow down the process of labor. Next one, we are talking about the sign and symptoms. So the sign and symptoms in dystocia is that the mother during the labor, um, they will have dehydration, tachycardia, and weak pulse, as well as feels of the bloating abdomen. And sometimes the mother also level of fever and also have weak contractions, and sometimes the contraction itself also disappeared. There could be also a sign of uterine rupture, where there is bleeding through the external orifice, and there's no contractions, and but then you can palpate there is the part of the fetal. Another sign is the intrauterine infection. So there is infections that happen inside the uterine, where the amniotic fluid become greenish, cloudy, and when it's come out, it's smelly. And sometimes it also mixed with meconium because the baby becomes stressed. And then when we do temperature through the rectum, it will be feverish, or about 37.5 degrees Celsius. And there's also another sign and symptom, which is the fetal distress signs from the baby. So it's probably because of the meconium that is already been mixed inside the amniotic fluid, as well as when we do the fetal heart rate, we'll figure out that there is a irregular fetal heart rate. And the baby movement obviously will be reduced, or sometimes the baby also will move hyperactively during this time of stress. And the complications of dystocia will then cause effect to the mother as well as the baby. So in the mother, because of the infection, it can lead the mother to sepsis. And there's also acidosis that can be caused by the disturbance in electrolytes level, as well as dehydration, shocks, and organ failure. And the worst case is there is tear inside the birth canal. For the fetus itself, it can cause the baby to have fetal distress, and the baby can be born with severe asphyxia, which then will cause permanent brain damage to the baby, as well as there will be a traumatic labor, and then maybe there will be fractures in the clavicle, or a humerus, or femur, or even a brachial plexus injury. So during dystocia, there are many complications that can be happening to the mother and the baby. And how to prevent? So prevention start during the pregnancy. So we have to make sure that the mother um, really paying attention to the nutritional status, and that the baby and the mother are within the normal nutrition level, as well as we keep the mother dehydrated and keep the mother eating during the labor, so that mother will have enough power to go through the delivery. As well as we also emphasize mother and encourage mother to get used to pregnancy exercise, to start to relax the muscles, to learn how to breathe during childbirth, to not overwork during labor, as well as to introduce positions and also prepare mentally before delivery, so that when the delivery start to happen, mother are in good preparation. And also we ask the mother to really not to push before it is fully dilated, as well as not spending too much energy during the dilation of the cervix itself. So then we will reduce the possibility of the mother having lost energy during the birth, as well as the swelling through the birth canal. And most importantly, we emphasize that the mother do pregnancy checkup routinely at least 6 times during the pregnancy, one time in the first trimester, 2 times in the second trimester, and 3 times during the third trimester. And Also, we move on to the nursing diagnosis for dystocia. Here we can have labor pain as because of the cervical dilation. There is ineffective labor progress, as well as there are pressures on the tissues around the vagina. And also, the second nursing diagnosis will be decreased fluid volume, because that has been prolonged, the labor, and then there's also probably fluid restriction in order to prepare the patient to do C-section. And there will be also a risk for impaired maternal and infant bonding because of the prolonged of labor process, which can be characterized by the amniotic fluid mixed with meconium, as well as the reduced or hyperactivity of fetal movement. And the fatigue obviously will happen to the mother, and this will be because of the process of the labor itself, when the mother endured the pain during labor, as well as there is changes in the mother's emotional status going through the process of delivery of the baby. And there will be also a risk for infection, because there will be probably infection, and there will be changes in the emotional status and the presence of pain. And yeah, I think that's for uh, dystocia. Now I have here a case study of a patient, a female patient, Garfida 1, admitted 7 p.m. because of the premature ruptures of membrane. So the contraction remained irregular since this morning, and the mother seems to be anxious and fearful. And we can take here the nursing diagnosis risk for infection, and the goal is to keep the infection down. And also here we can see the nursing interventions and the rationales that we can perform to the mother, as well as we can also do an effective coping because of frustration with slow labor and delayed birth, so that the female will be able to perform, or we teach about the breathing techniques and also relaxation techniques, so then the partner also can be prepared during the childbirth, as well as we communicate and we give information about the progress of the labor, and then we be there to help the mother during the journey of um, labor. Now we move on to the premature. So the premature is happening when the baby is born between 37 weeks of gestation, regardless the weight. And the baby also normally born within the mature stage, which is 38 weeks to 42 weeks of gestation. And sometimes also the baby can be born after the 42 weeks, which we call it postmature. And in premature labor, what happened is that there are regular contractions that accompanied by effacement and dilatations of the cervix between the end of week 37. And this is actually the leading cause for prenatal morbidity and mortality in the world. And this the common obstetric complications, and also have a profound effect on the survival and the health of the newborn. In premature labor, what we expect, as you can see here, the baby will be very high risk for respiratory problem, infections, congenital heart defects, thermoregulation problems, low birth weight, and intraventricular hemorrhage, as well as feeding difficulties, which then will resulting in decrease of the stomach capacity, and also sucking reflex and neurological disorder that probably related to the hypoxia and also the birth trauma. And the premature birth can cause death in baby in the first month of life. And well, as you see, the baby who are um, born prematurely, they are still immature and they're not ready to adapt to the extrauterine life. And we have protocols to handle premature labor, especially in the case of preeclampsia, where the mother needs to be, the labor needs to be terminated, all the baby needs to be born, so that we can save both the mother and the baby. So we'll look into it from the journals that I've prepared for you to read this week. And the etiology for the premature birth is sometimes because the mother is too young and the mother is too old. We have a history of anemia on the mother. We noted that there is nutritional status problem in the mother, probably also because a condition of social economic, and there's number of parity that is too close or too much within a very close range of year, as well as the gestation interval. And there's also a history of eclampsia, and there's also antepartum bleeding, as well as another diseases that suffered by the mother, such as pyelonephritis, chronic nephritis, essential hypertension, or other diseases that are associated with the high temperatures, which can also cause a leading in premature birth. Another factor is because of the incompetence of the cervical. So some women, their cervix are very um, rigid, and it caused the pregnancy to be easily out. And also, probably the mother has a history of smoking, drug and alcohol abuse during the pregnancy, even as well as the history of multiple gestation. So, because of the multiple gestation, it cannot be contained enough inside the uterus, and then that leads to the babies to be delivered earlier than the term date. And there's also what we call rupture of the membrane. So the amniotic fluid, amniotic sacs, it's get ruptured, and then it leads to the baby to be born prematurely. As well as the history of miscarriage. So we really do a history a check assessment on the mother on their obstetric history to make sure that there is no history of miscarriage, because if there is history of miscarriage, it will then be one of the etiology that can cause another premature baby. And sometimes the mother, as usual, mother women, we work too hard, and it causes actually stress and pressure to the pregnancy, and then that become another factor that cause premature birth. As well as there is traumatic pregnancy. So the mother has experienced a traumatic birth before, and this then leads to another traumatic pregnancy, which then causes the mother to really struggle emotionally, and then leads to premature birth. Well, the sign and symptoms, there are painful contractions that happen every 10 minutes, just like normal labor, but then this happened before term. And then the cramps is around the lower abdomen, and then also there are a lot of increased discharge, blood and mucus from the vagina, as well as there are vaginal discharge. And we can see that there are also pressure in the pelvic and the vagina. Sometimes the mother also can experience nausea and vomiting. And here's what we do to a very small baby. So we put inside a plastic bag to keep the warmth, and the baby took the um, respiratory machine to help them with the breathing, as well as this nasogastric tube to help the baby to get nutrition. And what we do in order to do a support during this time is that we perform CTG to measure the strength of the contractions and also check the fetal heart rate of the baby. We can also perform transvaginal ultrasound to check the conditions of the uterus, as well as we can check also the mucus that is being discharged from the cervix, and we see whether the fetal fibronectin protein has been released and there is any disturbance in the uterus. We can also do the vaginal swab to see whether there is a bacterial infection that will then lead to premature delivery. Well, when we see that the patient is in high risk for premature birth, then we can do some therapy management, such as hospitalization. So we ask the mother to stay within the hospital so we can monitor both the health of the mother and the baby for sure. And we probably administered the drugs that will stop or reduce the contraction, which we call tocolytics. And we can also do the corticosteroid therapy in order to have the lungs to be mature. And we can also do the magnesium sulfate therapy so that we can reduce the risk for brain disorder, as well as if there are any infection that is happening, then we administered antibiotics, as well as we do a cervical ligation procedure. So we tied up the cervical so it will last, and we try to not get the baby born before the baby has time. And if then we have to do labor, so then we have to make sure that the parents, the mother and the father, they do understand about an ICU care. And as you can see, this is the picture of the kangaroo care that can be performed by the father. And the nursing diagnosis for premature could be anxiety because of the crisis. It could be also activity intolerance because we don't want to um, cause hypersensitivity, and we don't want the physical activity to then increase um, the problem. And also we can have the risk of toxicity related to the toxic or the dose or the side effect of the tocolytics, and we don't want to have and we have the what we call risk for fatal injury related to the preterm delivery, as well as we can have the acute pain related to the muscle contractions and the uterine contractions that is happening. And we can also mention about the lack of knowledge because there are lack of information that is being given to the family. This is a case study for a preterm newborn. So we have a newborn infant of 30 weeks gestation admitted to the NICU, and the infant is placed in the pre-warm incubator with the cardiorespiratory sensors applied. And the nursing diagnosis that we can choose for this patient is hypothermia because there are decrease of subcutaneous tissues and immature body temperature control. And yeah, the goal is to make the temperature between 36.5 to 37 degrees, and with uh, continuous monitoring of temperature as well as the incubator. And we observe also the sign of stress, and also we limit bathing and also avoid cold surfaces. Another nursing diagnosis that can be taken is the risk for impaired skin integrity through related to immature skin and poor nutrition and immobility. And here we try to have the skin intact because the wound that can happen to the baby is hardly to be healed or take longer time in a mature baby to heal rather than in a term baby. So we try to perform um, change position regularly, as well as we be gentle when we remove dressing, and also we only cleanse the skin with clear water, and also we observe whether there are signs of infections. And I will put these critical thinking questions within our forum, so I expect that you will be able to answer this as your assignment for this week. Now we move on to the postmature. So in the postmature, from the word itself, we know that the postmatures are the babies who are born after 42 weeks or more than the term stage. And here it could occur in 3 to 12% of the birth, and the main cause is actually because of the ignorance of the menstrual rates as well as the irregular menstruation. And the cause, the very, very basic or the main cause of this is still unclear, but some theories stated that there is a deficiency in estrogen as well as in progesterone that inhibit the contraction within the uterus. And then here the women also probably have the history of postnatal labor, and then one history of postnatal labor then leads to another history of postmature labor. And this is the conditions of a postmature baby who is probably soaked in amniotic fluid with meconium and probably have also problem in breathing. And the postmature pregnancy actually influences the mother and fetus. And in the mother, it could lead up to maternal death because of the large size of the baby that is being delivered, and also probably because of the induced labor with oxytocin or with medical device assisted delivery using forceps on vacuum. And this can also can be because of maternal increase of maternal anxiety um, and dystocia. There's birth trauma or even like postpartum hemorrhage and infection. And the risk for the fetus can be because the baby is big, macrosomia with the shoulder dystocia, and there's also can cause brachial plexus injuries as well as cephalopelvic disproportion, which then result in birth trauma and then leads to C-section. With the postpartum pregnancy, we have the higher risk of perinatal death as well as incidence of congenital malformations in babies compared to those babies who are born at term. The other pregnancy risks is that postmature pregnancy, the fetal mortality at week 42 is 2 times greater, but then the mortality around 43 weeks is 6 times greater. So um, what we can do is we then induce the labor or we do C-section. And this also can be caused by the uteroplacental insufficiency, where the function of the placenta gradually decline, and there is the progressive uteroplacental insufficiency as a mechanism actually for the fetal when the fetal is in distress, and there could also be death of the postpartum baby because it's not being born in a distress within the uterus. There's also a chance of developing meconium aspiration and intrauterine infection, which also increase the rate of perinatal death, as well as at certain point the placenta is aged and the perfusion, the profusions of oxygen, the supply of nutrients are then being decreased because of the conditions of the placenta itself, which will then cause the baby to suffer in stress within the uterus. Another thing is that the volume of amniotic fluid is also decreased, so there will be leaky, there will be less than amniotic fluid that will also cause the baby to have fetal hypoxia and increased risks of cord compression due to the cushioning effect provided by the sufficient amniotic fluid that normally present within the uterus, but now because of the number of amniotic fluid that is decreased, then there is problem and stress that being caused within the postmature gestation. The hypoxia and oligohydramnion also can cause the baby to have fecal meconium aspiration, which will then actually meconium is expelled because the fetus is in response for hypoxic disturbances, and this can compromise all the well-being of the fetus and cause also fetal distress. The nursing assessment on postnatal pregnancy, we then have to assess the date of the last menstrual period as well. And we just make sure that the antepartum assessment on the postpartum pregnancy, especially for the fetal movement, is being done properly. So we emphasize the mother to do baby movement journal, actually starting in the third trimester. So then we documented the movement of the fetal to just make sure that it is within the normal range, as well as we do assessment for amniotic fluid, and we do weekly cervical examination, and also we ask the patient to understand that there are various tasks that will be done to make sure that the fetus is actually in a well position and well condition, and we also um, be with the patient, especially the mother and the father, during this time of stress, because sometimes the stress and anxiety about the beyond the due date can then trigger anxiety, as well as we work on the patient coping capabilities and the support network either from friends or family during this time. for the nursing management, we also, as mentioned before, we manage the fetal well-being as well as we monitor the fetal surveillance, consists of the movement, the fetal heart rate, and if the baby wants to be delivered, then we also measure and conduct the induction of labor together with the um, OB/GY doctor. And during this time, we provide support, we educate the woman and the partner, as well as we provide care during the interpartum period. Well, there are therapeutic management that we can also do, which is actually collaborative. Do what we call cervical ripening, and we also administer oxytocin so that it will then cause the baby to be born. So when the baby postmature really is born, then we will see that the skin will be dry and cracked because of the desquamating, and then we can see that the nails are firm, extend beyond the fingertips, and we can also see the fat layers. Um, Sometimes the baby body is long and thin, and we can see that the vernix is absent, as well as there are meconium staining on the skin, nails, and even the umbilical cord. Now we have the nursing care plan here for the woman undergoing the labor induction. So we can take the anxiety as the nursing diagnosis, and then we provide explanation. We maintain the continuous physical presence. We explain each procedures, and we review the stress the coping strategies to face the stress, and as well as we help to put helpful measures to assist in coping and encourage to use the coping method, as well as we reassurance of the fetal status and the labor progress. Another that we can take is risk for injury. So here we promote the safety for the mother and the baby during the administrations of the induction, as well as we make sure that when there is discontinuation of oxytocin, or when the oxytocin is being administered, there will be pain related to the uterine contractions, and we then perform the comfort measures to make sure that the mother can cope with the pain until the baby is being born. Another one is that once you start the induction, you have to monitor the mother's conditions and the fetal conditions, as well as then um, if there is a need of C-section, you then explain and also be with the patients to just then make sure that the mother and the baby will be healthy during this stage. So that's for today's lesson. Here are the references that we use in this presentation today. Have fun!